The next talk is going to be very appropriate because you just heard from Dr. Pinto about treatment of neuroblastoma, which involves throwing the kitchen sink at kids and a great deal of toxicities, and Dr. Falcon talking about rhabdomyosarcoma, where these kids are getting alkylators and radiation. A lot of the therapies that we do and use in pediatric oncology are successful, but they come at a cost. And Dr. Picky Prasad is going to come talk today about survivorship in the Gulf South. She's the director of the survivorship program at the other children's hospital, whose name I always forget. Oh yeah, Children's Hospital New Orleans.
I don't have anything to disclose. Okay, so we're going to talk about what are some of the objectives of my talk today. So one, talk a little bit about background about survivorship. I'm going to give some very brief statistics about cancer in Louisiana. And then I'm going to talk about my survivorship program in the Gulf South and what the different models of care are available out there. And the big thing is going to be talking about the evolution of how we developed a survivorship program and what goals we have as we move forward. So background. So as you guys are aware, there are about 17 million survivors of cancer in the United States and more than 32 million worldwide. The current 5-year survival rate is actually very good and has steadily increased over time. So we have about a 69% survival rate for adults and 84% for children. By 2040, as a result of all the population growth and the overall aging, it's estimated that 73% of survivors will be over the age of 65. But that also leads to, you guys are not seeing my slide. All right, so I'm sure a lot of you guys are from the Gulf South, but I'm going to give you a little bit of an overview about what the Gulf South refers to. So this is actually the southern region of the United States, and it touches the Gulf of Mexico. So the states that are involved include Louisiana, Mississippi, the coastal portion of Mississippi, and Alabama, and the panhandle of Florida. Louisiana is home to about 4.5 million people, so it makes it the 25th most populous state in the United States and the 10th most populous state in the South. Most of Louisiana, as you guys are aware, is very, very rural. But the population is really concentrated in a number of different parishes. There's 64 total. And we are very racially and ethnically diverse. So while people of color account for 42% of the state's population, only 38% of the national population make up the same mark. And our minority population is very different from the national landscape. When you look at Louisianians, about 31% identify as African American compared to 12% of the United States. Hispanics account for 6% of the population in Louisiana, which is less than its share in the United States, about 18%. And over half of Louisiana's population, 58%, identify as non-Hispanic white. Over 1/3, 33% of Louisiana residents are actually children under the age of 18. But there are lots of challenges in living in Louisiana and the Gulf South. They include things like natural disasters that we're all familiar with, including hurricanes, but poverty is a very big problem. And Dr. Pinto referred to poverty in his lecture and how this can affect care, and we see that every day here. People in Louisiana that live in poverty is about 23% of our state compared to 15% nationally. And this has wide disparities, including we know that those patients that refer to themselves as African American have a higher rate of poverty than others. So African Americans are 3 times as likely to be poor as whites. As in other states, children in Louisiana are substantially more likely to live in a poor household than in anywhere else in the United States. So what does cancer incidence look like in Louisiana? So Louisiana versus, this is just a slide from our tumor registry, if it will stay put, that looks at our cancer hold on, backwards. So this looks like cancer incidence rates for all sites between 2016 and 2020. This is data for the Louisiana Tumor Registry. The cancer incidence is broken down by parish, and it shows that there are multiple parishes with rates of greater than 25% of cancer. Those are actually shown to you in the deeper purple. The 5 most frequently diagnosed cancers in Louisiana include prostate, breast, lung, and colorectal, and that also includes kidney and pelvis. Losing my mouse here. In the United States, the following is the highest rates: breast, prostate, lung, colorectal, and uterus. So we do have a difference here in Louisiana. When we look at the pediatric cancer population, so this is from 2016 to 2020, on average, Louisiana has approximately 200 total cases of childhood cancer. 203 was the average. And these are patients diagnosed under the age of 20. Louisiana's incidence rates for all sites combined were lower than the U.S. rates for both boys and girls. The black line shows the U.S. average for each of the tumor types as compared to Louisiana. And the most common cancer types from children and adolescents in Louisiana are leukemia, central nervous system tumors, and non-Hodgkin's lymphoma. Of all the cancer types, children in Louisiana had a slightly increased risk of rhabdomyosarcoma that you just heard about from Dr. Falcon. So what does this mean for cancer survivorship in Louisiana? The 5-year cancer survival rate for all children and adults diagnosed with cancer is 64%. And the highest number of cancer survivors by age group in Louisiana are those between the ages of 60 to 69 years. There are a higher number of white females and males who are survivors of cancer. For children between the ages of 0 to 19, there are 1,720 patients statewide who are cancer survivors as of 2020. And for adolescent young adults, and this includes patients between the ages of 20 to 39, there are an additional 7,927 patients statewide who are cancer survivors as of 2020. So these numbers tell us there are many survivors in the state of Louisiana, but are they getting the care that they need? And why is survivorship care so important? And I think the biggest thing is, are they aware of late effects? And late effects we'll talk about are things that happen to patients more than when after they complete their therapy. It's very important for them to identify late effects of cancer therapy, and we do this now with guidelines for survivorship that is included for both children and adults. And it's important because these will allow us to have interventions for secondary prevention of other cancers, but also different late effects. This helps us monitor psychosocial health and other supportive care in cancer survivors. And I think lastly, the biggest thing is it helps us promote and adjust healthy lifestyles that will hopefully allow these cancer survivors to live long, fruitful lives. So what are late effects? These are health conditions that persist or develop 5 or more years from your cancer diagnoses. They're commonly reported by cancer survivors, and they're reported to impact almost any aspect of health, and these include life-threatening to life-altering events. They contribute to cancer-related morbidity, and they predispose to an early mortality. And this slide is, I think, shows a really good depiction of all the different things that are affected for children and adolescents with cancer. The obvious ones are our organ functions like cardiac, endocrine, pulmonary, and we're going to go through some of those today. But there are things that we also don't always think about. Fertility and reproduction is a very big one that has come into focus more recently. Secondary recurrent cancers, psychosocial issues like mental health, education, employment, health insurance. These are very, very important. And then the things that all parents think about, growth and development. Emotional and social maturation is very important, as is intellectual function and sexual development. There are many, many factors that influence morbidity and mortality of the childhood cancer survivor. So each of these arrows indicates a different factor that affects morbidity and mortality, and it's along a continuum of care. All those things that are in red are those factors that cannot be modified. Those for which there are some future interventions that are plausible are in yellow, and those where there are known targets for interventions or areas are those that are listed in blue. So how do we take care of these survivors? There is a very systematic approach that is called risk-based care. That means that no two survivors require the same degree of care, but the approach should be exactly the same. And the approach depends on many factors that are listed here. Each of these factors should be considered for every single survivor that is out there. And some of the examples we're going to go through some organ systems, and that will hopefully explain why risk-based care is important. So this table shows the predisposing therapy that puts cancer survivors at risk for potential cardiovascular effects. So if you look at the first column, those are the predisposing therapies that we worry about. The second column shows the potential cardiovascular effects survivors are at risk for. And the last column discusses the health screening that we perform to assess this risk. These guidelines are actually taken from the Children's Oncology Group. These are guidelines that are updated every 2 to 5 years, and they're evidence-based. These guidelines go through a very rigorous process, and there is more than 100 and 150 people that actually kind of go into producing these guidelines. When you're looking at this table that we're showing, one of the things that you'll notice is All of the oncologists worry about things like anthracyclines, which is a common drug that we use for many, many of our cancer therapies. But there are other things that we should also always consider, and things like that we don't always talk about. So if you have a CNS tumor survivor or a brain tumor survivor who received cranial radiation, they also are at risk for cardiovascular effects. So it's important to think about these things outside of what the common things are. And this is the common one, right? So this is anybody who had a history of chest radiation or anthracycline receipt. We know they have a risk for cardiovascular injury. So how do we screen for them? It's really important that all of these patients get a detailed yearly history, and they should all get a baseline echo for evaluation of their QTC. If they enter our late effects program, but definitely a baseline. And then they should get an echo or a MUGA scan that should be evaluating systolic function and global strain at baseline, then periodically based on dose of radiation and cumulative anthracycline dosing. And this has recently undergone a change, so most people now will get it about every 5 years, but there's still a few people that will get it annually or every 2. Endocrine late effects are the most common late effects that most survivors have. And this slide outlines how PCPs and survivorship clinics monitor for endocrine late effects. We should always look for history of constitutional symptoms. This is very important during childhood. It's important to monitor things like growth and pubertal development. We use a number of different tests to look for growth. One is bone age. We also always obtain hormone levels at age 13 that include LH, FSH, anti-Müllerian hormone. And this will tell us whether growth or puberty is accelerated or decelerated. We try to obtain annual free T4, TSH. Hypothyroidism is one of the most common endocrine effects that we see, and it's one of the most treatable late effects that we see. And we always refer to our endocrine colleagues to help us when we run into trouble. So as our childhood and adolescent cancer patients have continued into survival until adulthood, we now really believe in the importance of evaluating for gonadal dysfunction. So providers should know onset and tempo of puberty and menstrual history in all females. And symptoms of sexual dysfunction and menopause should be discussed and asked about at every visit. We refer to our gynecology, urology, and endocrinology colleagues quite a bit. And I think this is difficult for some of us pediatricians. Talking about sexual dysfunction is not an easy topic. And so I think this is something that needs to be learned. And we try to do this quite often in our survivorship clinics. Another common organ system that's affected is your lung system or pulmonary system. There are a variety of different drugs that can cause issues that include bleomycin, BCNU, CCNU, busulfan, and others. The younger you are at the time that you receive these drugs, the higher risk of developing lung injury. And monitoring includes physical examination, pulmonary function testing at variable intervals. This is one of the slides that I think most oncologists don't like to see. We realize that what we do is to try to cure our patients, but we've also now realized after looking at data for the last 40, 50 years, that after we cure our patients, the risk of secondary malignancies does not fall. In fact, it's very, very present. So the malignant risk is now driven by different things: breast cancer, thyroid cancer, sarcomas. There are also new carcinomas that are emerging. And there's some decrease in some things like secondary leukemias, malignant nerves, CNS tumors. But there are some other things that we are seeing a lot more of, including melanomas and skin cancers. Psychosocial late effects are prevalent from the time of diagnosis all the way through survivorship, and there are multiple studies that have shown that childhood cancer survivors are more prone to academic underachievement, vocational limitation, and underemployment. We know that childhood cancer survivors are less likely to live independently or be married, and they're also more likely than their siblings to engage in risky behaviors. So we know all these things, but what roadblocks are we seeing when we take care of our survivors? The biggest one is actually an uninformed survivor that has a knowledge deficit about their cancer diagnoses. Imagine if you were diagnosed at age 2 with leukemia, and now you are 30 years of age. You probably completed all your therapy before you were age 5. So do you really know what type of leukemia you have? Do you know what treatment you received? It is something that needs to get passed on from a parent to a physician onwards. But if you've moved multiple times, which a lot of people do, that knowledge may be lost. So it's really important for our survivors to know about their cancer diagnoses, but also specific treatment modalities they may have received. And this helps us inform them of the cancer-related health risks they're at risk for. This also informs us what health screening they should be doing, and they should be taught these things so they can learn to have some risk reduction. One of the biggest things we face is insurance issues. There's a lack of insurance. You can be unable to receive insurance for a multitude of different reasons, including being underemployed, disabled, and things of that sort. And we're all well aware that depending on insurance status, it's going to dictate where you get your care. So you may not be able to go to a subspecialty center to get your care, and that's really important as well. Other roadblocks we face is having an unfamiliar, uncomfortable provider. A lot of these survivors are actually seen in the general health system, so they're seen by their primary care physicians, internal medicine doctor, family practice practitioner. And so the practitioner may be uninformed about cancer-related health risks and screening. This is a rare and heterogeneous diagnostic group. Pediatric cancers are all treated very, very differently, and there's also always new things that are emerging. So it's really hard as a PCP to keep track of who should get what screening is available, and there's really no incentive to gain expertise in survivorship care. So for those of us that live here in New Orleans, this picture is going to be something that most of us know. This is Charity Hospital in New Orleans. It started in 1736 as a hospital for the poor, and the current hospital was built in 1939 and had 2,680 beds, 200 of which were pediatric. The LSU Health Science Center was built right next door in 1931 under Huey Long, and this actually served as one of the largest populations of uninsured citizens for the longest time. It boasted the #2 Level 1 trauma center in the nation, with the #1 being at Cook County. And there was a very robust cancer program at the hospital between 2000 and 2005, but unfortunately there was not a survivorship program. In 2005, as all of you are well aware, Hurricane Katrina hit and the hospital sustained severe damage, and there subsequently was closed, and now across the street we have a beautiful new building called University Medical Center. But the cancer program in Louisiana has actually been undergoing a rebuild since then. There are now many, many different programs out there, and so between 2006 to 2010, new programs have emerged. But unfortunately, during that time period, there still wasn't a dedicated cancer survivorship program for either children or adolescents. So in late 2011, I was asked to come to LSU to give a grand rounds on late effects of pediatric cancer, and was subsequently recruited as a faculty member to start a survivorship program. I was enthusiastic, but it was very daunting, and so there wasn't really a framework in place or infrastructure. And so we kind of went back to the basics. And so what were the hallmarks that we wanted? One was the survivorship care plan. What this is this is a record of all the care that was received, and that's important, has important disease characteristics. This is easy to follow guidelines for monitoring of late effects that survivors can read and understand, but it's also something that a primary care physician could understand. And our goal was to provide this for all pediatric and adolescent patients that had been treated for cancer at our hospital, and then we did open this up to anybody who'd been treated in our region. There are a number of different models of follow-up care that are out there for survivorship, including specialist-led, primary provider, and shared. So a specialist-led model is that of which a pediatric hematology, oncology, or internal medicine physician is trained in survivorship, and they actually lead a follow-up clinic or survivorship program. A primary care provider model is that model that is outside of a cancer treatment center, led by a primary care. And a shared care model is a combination of the above two. So this is when an oncologist provides or guides periodic surveillance that's available to evaluate patients when a potential cancer-related concern arises, but the PCP carries out routine prevention and health maintenance interventions and manages comorbid conditions. This is probably the best of both worlds, and really it should be the goal for most centers. Since we were starting fairly small, we actually we started a specialist-led model survivorship clinic. So the goals were to prepare a treatment or survivorship care plan for our patients with input from other providers, including their oncologists. We wanted to give this treatment or survivorship care plan to all patients upon completion of treatment. And this record would contain a summary of all the care they received, important disease characteristics, and a follow-up care plan that incorporated available and evidence-based standards of care per follow-up guidelines that would be updated annually. Our original eligibility criteria for our clinic, we called our clinic Treatment After Cancer and Late Effects, or TACL, was that patients had to be 2 to 5 years from the completion of therapy. They had to be in a remission. They had to be referred by their pediatric hematologist oncologist, though outside referrals were welcome. And the goal was to educate families. So we really encouraged our survivors to bring a family member with them to their initial visit. And then our other goal was to help transition our patients to adult services once they hit the age of 25. So this was the beginning of our first clinic. We had our first clinic in January of 2012. We had 2 patients scheduled, and they both came, and we were thrilled. We had actually expected our clinic to grow very quickly because we had a number of different survivors out there. But however, the onslaught of referrals from my colleagues didn't happen, and then we started trying to figure out why. We also realized that once referrals did start coming in, that patients were more likely to no-show or cancel these appointments because they didn't know what the clinic actually provided them. We also deliberately had decided this clinic was going to be outside of our routine hematology oncology clinic. So the clinic was held in the afternoons, so patients didn't have to miss much school. Labs were done on their way out, and we tried to schedule as many different subspecialists to see them the same day for convenience. So how did that work for us? Well, it didn't. So we had to learn a lot of hard lessons. One was our oncologists had a really hard time referring patients because they didn't want to stop seeing their patients. For those of us that are oncologists, you develop a very special relationship with these families. And our families did not want to let go of their oncologists. So we changed our framework around a little bit. So all disease surveillance continued with our primary oncologist. And though I am an oncologist, I continued to follow them every other year or so for a survivorship visit that was completely separate from their oncology visit. We did not focus on their disease at all. We only focused on late effects. I also learned very quickly, treatment summaries take a very long time to create. We didn't have an electronic EMR system until about 2018. In 2015, we had a very rudimentary one. So we had paper charts. So I was going through paper charts manually and listing out every drug, every dose. It was quite an arduous task. And then subspecialists were enthusiastic about seeing our patients, but we also learned that these visits were very, very long. Some of these families were here for 4 to 5 hours, and they were exhausted, and they didn't want to do that. We learned that we needed to have a mechanism to keep track of patients, and we needed a database to capture patients so we could actually learn some more about what's happening to our families, but how can we improve as we go along. And slowly my team grew from just myself to a full-time social worker, a psychologist. We have an education specialist and a nurse navigator that sees our patients. In order to make my treatment summaries a little bit more streamlined, we enrolled in a Baylor program called Passport for Care. And I was actually very lucky I was able to do that after my very first patient. Most of my things were updated into Passport really quickly. What Passport did was it actually allowed us to produce a treatment summary in a Word document that we could easily manipulate. And this also allowed us to print all the relevant health links for our families. And health links are sheets that have very basic information about disease and late effects that are in layman's summary and in multiple different languages that our families can have. All of our families receive a survivorship binder, which contained a copy of their treatment summary, relevant health links, information about vaccine eligibility, and information about financial resources, including how to get insurance and multiple different scholarship opportunities if they were interested. Our database development has taken many approaches. We used Passport for Care in 2012, but we were not able to get that data back from Passport for a few years. So then we put everything in an Excel spreadsheet to capture small bits of data. We're now able to export all of our data from Passport into an Excel spreadsheet, and which is very elaborate. And then we've actually been able to slowly but surely convert all of that into REDCap, which is a much more secure system, and it allows us to do some research on our patients as well. So my clinic would not be possible without funding. We have funding from lots of different sources. I was actually given initial funding to start my clinic through a Jeff Gordon Children's Foundation grant and a Hyundai Hope on Wheels grant. And since then, we've also been able to get St. Baldrick's infrastructure grant since 2017. That's allowed me to get a CRA. And we just recently got an impact award from Children's Cancer Cause that allowed us to buy some iPads in clinic that allow us to fill our patients can now fill out questionnaires, which were always done on paper, now through a computer system through REDCap. And this is just a brief timeline of all the different things that we've done since the late December 2011, all the funding that we received in order to get our clinic up and running. And the current structure of our clinic is that it's offered 3 half days a month, usually the second and fourth second and fourth Thursdays and the third Fridays. And it's multidisciplinary. So like I mentioned earlier, it's myself, a social worker, research coordinator, educational specialist, and we do have a number of subspecialists. If the families are interested, they can see endocrinology, cardiology on the same day. We now have a meeting in the morning of clinic before clinic starts to actually discuss our patients. So it's multidisciplinary. So everybody's on the same page about what we're going to be talking about. And all patients continue to see their primary oncologist if they're still needing imaging, unless a primary oncologist and the patient decide they only want to be seen by me. We have limited our clinic to only 6 patients scheduled in any given clinic, and each appointment's between 60 to 90 minutes, which gives us a lot of time to actually spend time with them and help answer questions. So currently, we've actually have greater than 600 patient summaries that have been created, so more than 600 patients have been seen. All of our eligible patients receive an electronic token from Passport for Care that allows the treatment summary to be uploaded to their phones. We started this in 2017. We also keep data on transition processes for those that are 22 years of age and older. And we've also started identifying adult providers in the city that are willing and able to see our survivors, and have a list of providers across the state that are willing and able to see our patients. In 2018, we started a telemedicine visit clinic, which was very, very helpful with COVID, and we have continued that. We've started doing remote consenting for studies as well. And so some of the demographics of our last 300 patients that we saw: 51% male, 49% female, 46 identified as Caucasian, 23% as African American, 8% as Hispanic, and 20% as multiple ethnicities. 102 or 34% of our patients are leukemia survivors, 17% are lymphoma survivors, 11% central nervous system survivors, sarcoma and renal tumor 10%, 7% neuroblastoma, and more recently we have bone marrow transplant survivors. So 4% of my patients now are bone marrow transplant survivors. So of the last 300 that we took care of in clinic, 215 of them reported at least one late effect. It's a very large majority. 95 reported multiple late effects. 23% reported a neurologic late effect, and 70% of those included things like attention deficit disorder, developmental delay, learning issues, or neurocognitive issues. So the goal of our survivorship program is to educate. We want to educate our cancer survivors, healthcare providers, and families. We know that this is critical to promoting quality cancer survivorship. There are multiple studies that have evaluated health knowledge among childhood cancer survivors and reveal that there are significant knowledge deficits, misconceptions regarding diagnoses and treatment and therapy-related health risks. We also know in Louisiana, 25% of our residents have a college degree. But our survivors tend to have a lower educational attainment, so educating them when we see such a high incidence of neurological late effects has been quite a challenge for us. So what are the barriers for survivorship care? I think the biggest one is funding. Funding for a survivorship clinic is not always easy to get. This is not a money-making clinic by any means. I think there's downstream revenue and things like that administrators like to hear about, but there really isn't a lot of money for this. Physicians are not always versed in late effects and surveillance, and this could be a challenge. Lack of insurance is a challenge. Lack of knowledge is a huge challenge as well. And in order to help study some of these things, we do have a lot of open studies looking at late effects through our clinic, through COG and ECOG Akron. We're also opening some studies through Alliance, so a number of different cooperative groups to try to get as much information as possible for not just our pediatric patients, but our adolescent young adult patients as well. And then what are some of the next steps for survivorship care in Louisiana? Survivorship care continues to vary. And so I think the biggest thing is working on collaborations with adult partners in adult oncology and primary care, and trying to really build that shared model for adult cancer survivors and for pediatric and adult oncology survivors. And I'm happy to take any questions.
So a lot of the things that the difficulties you said, so I have a young adult survivor program in Oshner, and the paper charts.
Yep.
Oh my God, trying to piece together. Mm-hmm. The long appointments, because it's about a 3 to 4 hour appointment, right? We do that because a lot of these people are traveling.
Yes. Yes.
You sit there and run back and forth, but on the other hand, they sit there and they visit.
Yeah.
Deal with that.
Yeah, that's a challenge. It's a challenge. We have actually, if you live more than a few hours away, we give them an option of actually staying at a Ronald McDonald House or someplace local overnight. But the other thing is I've actually started partnering with places that are farther away to do echoes, EKGs, and just have them fax results to me or send results to me. That way, they're not spending as much time with me as they are, getting all their work done. But it's quite a challenge in our state. And getting them to come.
Young adults are going to put that behind them. And
getting them to come. We are, on average, we ask our patients 3 to 4 times before they're actually scheduled and seen in our clinic. So it's a lot of following up and following through.